over to, I will stop sharing my screen so you can share.
Fabulous. Thank you. Kate, you're going to share slides?
Yes, I will.
Okay.
Once they take it down, and I'll pull mine up.
Okay. Well, while you guys are doing that, I'll just start talking. So thank you all, and thank you for inviting us today to talk about our Maternal Health Emergency Department Toolkit. So this comes out of, and maybe some of you, for you, this is the same from your PQC, years of my being a founding member of both of our maternal mortality review committees. We have one, our MMRC, that really looks at the direct causes related to pregnancy of maternal mortality. And then our second, and that's been around for over 20 years, about 25 years now. Our second maternal mortality review committee, because we are from Illinois, large state, large population, and unfortunately a lot of maternal mortalities, we formed a second committee called the MMRCV, which V stands for violence, looking at deaths due to homicide, suicide, overdose, any other substance and mental health conditions. So in my many years of being part of the Maternal Mortality Review Committee and reviewing the deaths, we saw a real growing trend in Illinois. We have a large rural communities in Illinois, in central and southern Illinois. I'm assuming it's similar for Georgia with rural communities and a scarcity of obstetric providers. And so more and more women are visiting emergency departments both during pregnancy and in the postpartum period. And a lot of the women that have died spent a lot of their time in emergency departments. You can see from this data that, close to 3 million pregnant patients, and this is just pregnant patients, visit an emergency department every year in the US. So what's happening in Illinois is not very different from what's happening in other states. And this doesn't even include the postpartum period. Massachusetts, which shared their data, has a high ED use during pregnancy, and that's associated with an increased risk of SMM. And for us, it showed an increased risk of maternal mortality. And across the country, and especially in Illinois, we see multiple use of emergency departments during pregnancy and in the postpartum. So 2/3 of our women who died, we're not even talking about severe maternal morbidity, visited an ED at least once while pregnant or in the postpartum period. And this is much higher even in the rural areas. And many visited an ED 2, 3, and 4 times in Illinois. So what we thought is, we're not saying that the deaths that happened in Illinois were due to any fault, in quotes, of the emergency departments. But what we thought is emergency departments then are part of the solution. They could be an excellent resource for providing better care. Yes, we have to deal with the OB scarcity that's happening. We have to deal with the fact that a lot of women don't have PCPs in their during their postpartum period, but those are different kinds of problems. And in the near term, why not work with the emergency departments to provide better obstetric care both during pregnancy and in the postpartum period? And there's been other calls for this. ACOG and CDC have been working on this and recommend ED education and training as well. CMS, Central Management System, have new standards saying that all EDs must have adequate OB provisions and protocols, and they have to complete an OB training every 2 years. So we thought this is especially timely. And our own Illinois maternal mortality review committees have recommended enhanced education and engagement in obstetric care in mental health and substance use disorders for all EDs. So we thought the timing is right. Let's go on, Kate. Thanks. So what did we do? We formed a statewide task force to actually develop a training for the emergency departments. And this just gives you a brief overview of who was included. A lot of maternal health people, some emergency department medicine people. In retrospect, it would probably have been good if we had even more. A lot of nurses were involved, physicians. Illinois is a regionalized perinatal network, and so we had all the perinatal administrators from across the state. And it was really important to us that this be inclusive across the state and not just be focused on Chicago. And you can see that people were from across the state. Next slide, Kate. So what we came up with was 5 modules, basically. It's long. It's almost 4 hours. But when we work with the EDs, we tell them, take a year to do it. Think of it as an hour every quarter, and over a year, you'll be done. Now, some people are doing it much faster than that. And Kate's going to talk about our pilot and then our training, our expansion across the state. But we came up with 5 modules. Module A is basically an introduction to maternal mortality in Illinois. We wanted the emergency departments to understand that we view this as their part of the solution, helping to decrease maternal mortality and morbidity. So we present them with the data from Illinois MMRCs. They usually have no idea about how often pregnant women are visiting EDs across the state. We talk about how important it is and what their role is, and how important for the service lines, especially ED, OB, psych, to work together. Next slide, Kate. Module B seems to be one of the favorites. It's acuity assessment and then management of various perinatal emergencies. And it goes through the maternal warning signs and all different treatment algorithms that either have been adapted or developed by the statewide task force. Go ahead, Kate. And these are basically the case studies within Module B. There's one on sepsis, one on hemorrhage, pulmonary embolism, hypertension, and ectopic pregnancy. And as people are doing the training, they're working through, they don't know that it's a sepsis or a hemorrhage. And then in the end, there's a little quiz, which actually they wanted put in. So we put in a little quiz. And they have to figure out, what was the condition that this woman suffered from. Next slide. The third module is one sort of near and dear for me, which is on the screening and treatment for perinatal mental health and substance use disorders. What we see in Illinois, and I'll be really interested to hear from your Georgia data what you found. The leading cause of maternal mortality overall is substance use. And what's happening is a lot of our women in Illinois are overdosing, coming to the ED, getting stabilized, and sending away with no referrals, not adequate screening, not being given Narcan. We're seeing that slowly change, so that's the good news, right? So what we said to the EDs is, look, if somebody comes in and it's really an emergency, you're not going to start screening them for substance use disorder. If they're overdosing, you're going to stabilizing them. If they're hemorrhaging, you're going to stabilize them. But we all know that the waits in EDs are very long, right? So we came up with several very simple screening tools, universal screening tools that have been validated for depression, anxiety, and suicide risk and SUD. We don't even ask them to do the PHQ-9 or the Edinburgh unless they want for depression. There's a PHQ-2. Start with that. If there's anything alarming, go on to the next step. So we really try to make it as simple as possible in terms of screening. And then really going through how do you assess patient safety concerns and stabilize them? So if they are overdosing, what are the next steps? And that was one of the biggest things that we heard from the EDs is, yeah, we can screen and then we have no idea what to do after that. So this module includes every resource that we could dig up in the state of Illinois and even some national resources where it would be fairly easy for them to access. So that we're telling them definitely screen, treat if you can, but here are the next steps if you don't have the personnel or the resources available. Here's what you can do. Next slide, Kate. Module D is trauma and resuscitation and pregnancy. And this is a module that the EDs seem to appreciate. You know, really, if you have to resuscitate a pregnant patient, do you have two patients or do you have one? Is she greater than 20 weeks gestation? Is she 15 or less than 20 weeks? So really thinking about the best practices and early warning signs for trauma during pregnancy. And we do, there's a practice using ACLS, cardiac arrest in pregnancy, and lots of algorithms for them to find. Next slide. The last module is best practices for discharging a patient from the emergency department. And this is something that we found in reviewing our maternal mortalities, is that a lot of women were left the ED without any appropriate discharge, no consultation with an OB provider or a PCP, not given a follow-up appointment, not given any resources, referrals, and certainly a lack of warm handoff. And again, it was digging up all the appropriate resources and being able to provide them for the EDs and saying, this is what's in your area, this is what's across the state, these are some national resources, which I think have been very much appreciated by the ED staff. Next slide, Kate. So, important to remember and think about is the training that was developed was really rooted in MMRC data, findings, and recommendations. These 5 modules weren't just modules we thought would be important. They were actually rooted, evidence-based, and rooted in the data. They were developed by a cross-section of statewide experts. It is 4 hours of content, but it's over a year. We provide free CME because that seems to be really important for them. It's a self-guided virtual training, so it's hosted on our learning management system at the University of Illinois. Kate can talk more about that. And the important thing is it meets a lot of state and federal training requirements, so that's important for them too. And I think at this point, I'm going to turn it over to Kate to talk about, before we did a statewide rollout, which we're in now, we did a pilot.
Yes, thank you, Stacy. So yeah, before we start making it available to all 188 emergency departments in Illinois, we tested to see how it worked. And we did this by partnering with the regional perinatal centers that Illinois has, and also offering this at 6 hospitals. And we did these at 6 hospitals with the goal to do a different array of environments, whether it's ones that are big tertiary centers in Chicagoland, or whether it's a rural non-birthing facility, or various patient populations, to see, does this work in different environments? Because the goal was to make it a statewide training. And we evaluated it based on learner surveys and medical record data extraction. And the goals of this program were fourfold. One of them, quick and easy, is there a sign up in your emergency department that is patient facing that alerts them to say and be vocal about, I'm pregnant or I have been in the past year, to increase awareness about this status? And then for clinicians and staff who are treating patients, to ask patients of reproductive age, are you pregnant or have you been in the past year? And document this in their medical record, even if the answer is no, just so that way documentation can happen, because the answer maybe could be yes and you didn't know. And then also to screen, treat, and refer patients in accordance with all the different facets that Stacey just went over in regards to screening patients for mental health and behavioral health disorders who are stable, performing adjusted CPR, providing resources upon discharge, and more. And then with our pilot results, across 6 hospitals, we had 281 emergency department staff and clinicians complete the entire training. And we had almost 90% total, at least start it in some capacity, finish one module, maybe they got interrupted, didn't come back, or maybe they made it halfway through. And not surprising, most people said, I learned something new. One of the feedbacks that we often hear when we're starting to make this training available to lots of different places is, oh, we already teach about that, or that information is already covered in the education that our staff has done, either in their academic education or in their education that we offer. But we actually are learning that individuals who complete this training are learning something new, which was really great to see. And then that first kind of program goal that we had, we went from known to all hospitals having a sign up in the emergency department that's patient facing. Wonderful to see. And then we looked at behavioral changes. We collected medical record data before we started offering this training, periodically throughout and at the end. And from the very before everything started to the very end, we saw changes in clinical practice. We saw increases in pregnant and postpartum patients being referred or transferred to higher levels of care. We had increased asking and documentation of pregnant postpartum status, increased communication between the OB and the ED with the OB or MFM departments. Really great to see those silos being connected. And then increases in screening for mental health and behavioral health disorders. And then we did a little bit further breakdown of, well, okay, we tried this in different environments. Does it still work? And the answer was yes. We compared a small sample size, unfortunately, but we'll go bigger with our statewide version, the rural versus non-rural areas, those with an obstetric unit versus those without. And we found that the training was impactful regardless of this. And like before I start talking about statewide, I like to give people a little bit. We as researchers and implementers can talk about how great this thing is that we built, but it really says something when it comes from the people who did the training. We did some evaluation interviews, and this is what a couple of people shared with us. One person said, I'm glad people are taking this seriously, and I'm glad that women's health is getting more attention than it deserves. I think it's about time. And another person shared, I will definitely ask more often about postpartum status. I think before this module is easily overlooked. And they shared that that's because patients are often going to the local OB/ED and they aren't always here for a primary medical concern that's not related to their pregnancy. And then what we did is, based on the evaluation and information and data collection that we heard from the pilot, we revamped the content. We made it more interactive. We made it even easier to access with this more robust statewide rollout. And we started making this available in February of this past year, so just a couple months ago, out to our 188 emergency departments in Illinois. And as of right now, we are actively offering this training at 56 of those emergency departments and continuing to have further discussions with EDs every week to make it available. And one of the things that we really like to look at, and maybe this can speak to you all in Georgia as well, is we're really proud to see the number of hospitals that don't have an obstetric departments receiving this. It's a training that can be really, really impactful for them. We are continuing our partnership with our regional perinatal centers. They are centers of education and resources and support that are wonderful partners on this. We're also doing medical record data collection, again, of a sample to see was their practice changed statewide. And then it is available on 2 different methods. So we have it on a statewide system on an online learning management platform where we have free CMEs available for all clinicians. That's advanced practice providers, nurses, and physicians. And we also make it available if it works best for adding it to a hospital's internal learning management system. Let's see. My clicker wasn't working, and I just like to give this thing. So we're talking with you all, but we created this. It's a free resource. We love to see it going to so many different places. We've had it with you all in Georgia, and we've talked and distributed this freely to half a dozen more other states and organizations throughout the US, so that way they can utilize it and they can implement it. We would love to see you all use it as well, and just hope to hear back of how are you using it, how is it being adapted, and what kind of wonderful results you're seeing. And if you want to request this, we make it available. We just ask that you fill out a survey, and we can follow up afterwards if you would like that link, also available here. And then this is our research team. It's not just Dr. Geller and myself, it's our other colleagues, Emily and Lauren, in addition to so many others who developed this content, actively implementing, and of course the emergency departments that make this work possible. Our contact information, we also have a website where this is available. And again, the survey, if you want to talk with us further, you can also have our email or to submit a request for the training content. There are references. I'll stop sharing my screen and open it up to some questions. All right, let me stop sharing. All right,
Great.
there we go.
Thanks, Kate. We wanted to leave a lot of time for questions.